My name is Takayuki Akahoshi from Japan. I'd like to talk how to attain 10,000 premium cataract per year. I'm a director of Mitsui Memorial Hospital in Tokyo. This is a charity hospital established more than 100 years ago for the poor people living in Japan. I'm working here in this Mitsui Memorial Hospital for 25 years as a director. When I moved to this hospital, the number of the surgery per year was only 300 per year. Then I started to perform the phaco emulsification, and then I developed the phaco Prechop technique. The surgical time was remarkably reduced by phaco Prechop. The number of the surgery is growing up and up. In 2002-2003, I started to perform my phaco surgery through sub-2, very small incision. So the surgical result was good, and more patients come to our hospital. Nowadays, I use toric astigmatism to correct the pre-existing astigmatism. Now, I operate more than 10,000 cataracts per year. I have many questions. How can get so many patients to operate in Tokyo? There are hundreds of hospitals, university hospitals. There is so much competition in Tokyo. How can get so many patients? The reason I can get so many patients is that the quality of the surgery is much better than the other surgeons. The quality of the surgery augments the quantity by itself. I have more than 1,500 doctors who don't perform surgery. Just refer the patient to me. I do the best for the patient. I use the best material, and I use the best machine and best technique for the patient. The result is good. The patient is happy, so more patients come. The patient brings patients. The doctor refers more patients to me. That is the reason why I can get so many patients. In 2015, I operated 10,398 cases by myself, alone. In all cases, I used the phaco Prechop. I never used Femtosecond laser. All the cases performed through sub-2 millimeter incision, but in some myopic cases, which require 3-piece acrylsulfone implantation, I implanted in 1.5% of the cases. And look this number. The number of the toric implantation is 4,074. Nearly 40% of my cases received toric lens. Strange to say, the toric lens is regarded as a normal lens in Japan. So the cost for the patient is the same, even it is a normal lens or toric lens. So I implant any patient who has an indication for the toric lens. I had a posterior capsule rupture 30 cases among 10,398 and no endophthalmitis. For these 25 years, I have only one patient which required corneal transgraft, who was a Guttata patient after glaucoma attack. So my corneal anterior loss is no problem. Most of the cases have the 0 to 3% loss after the surgery. Now I'd like to talk about the quality of the surgery. All my surgery is performed through a sub-2 millimeter incision. As you know, the incision size is smaller, the less astigmatism. And it is also important to reduce the surgical time to prevent the risk of the endophthalmitis. For this sub-2 millimeter incision surgery, wound protection, incision protection is one of the most important points. To attain this, I always perform phaco Prechop, and I use Harmonyx, new phaco tip, or new phaco machine, Centurion. I always use bevel-down burst phaco. I will explain about the phaco Prechop. Phaco Prechop is a technique, mechanical nuclear fracture, performed prior to the phaco emulsification. It is a very old technique. I developed this in 1992. Since then, all my surgery is performed using this technique. When I performed the divide and conquer technique, it required a lot of ultrasound energy because tip is not completely occluded, so there are so much loss of the ultrasound energy. But by phaco Prechop, the nucleus is divided into pieces under the viscoelastic material because phacoemulsification. Once the nucleus is divided, all the ultrasound energy is used to emulsify the nucleus. Even with such an old phaco machine, Prechop nuclear fragment can be so quickly removed like this. Nowadays, Femtosecond laser can Prechop the nucleus. But there are so many procedures. You have to docking the disposable cone and the OCT imaging, programming, and emission, and then move the patient to the another room for the surgery. But we can make an incision quite easily, and any doctor can perform Capsulorhexis quite easily, and Prechop, as you see, in a few seconds, we can divide the nucleus completely. The drawback of the phaco Prechop by femtosecond laser, it depends on the pupil size. If the pupil is small, you cannot Prechop the nucleus completely. And also the posterior plate of the nucleus can never Prechop using a femtosecond laser. So there are so much limitation. Always posterior plate remains, and it depends on the pupil size. So most of the famous surgeons, femtosecond cataract surgeons, uses their own devices to separate the posterior plate of the nucleus to attain the complete separation after using a femtosecond laser. So the femtosecond Prechop depends on the pupil size, and it is very difficult to deep set eyes and narrow lids or cases with advanced glaucoma, clouded cornea, or dense cataract. And it costs a lot. $500,000 US. But the manual Prechop is very cheap. So merit of manual Prechop is applicable any case. Any type of the cataract can be managed using this manual Prechop, and no energy required, and complete division can be attained. And the most important point is high cost performance. So before you're performing the phaco Prechop, there are three important prerequisites. First, corneal protection using dispersive viscoelastic material. Second, making the Capsulorhexis completely and sufficient hydrodissection. The procedure of Prechop will never damage the corneal endothelium, but once the nucleus was Prechopped into smaller pieces, during the phacoemulsification, small nuclear fragment may come into the anterior chamber and it may hit the corneal endothelium. So protection of the endothelium using dispersive type of the viscoelastic material is mandatory. Make a Capsulorhexis a little bit smaller than the optic size. It should be quite easy using the forceps. And another important point is hydrodissection. I always use this, my own hydrodissection cannula. It is 27 gauge cannula bent, and its tip is tapered a little bit. Small trick is to use a small syringe, 2.5 millimeter small syringe should be used. If you use a big syringe, you cannot perform the sufficient hydrodissection. Important point is to use a small syringe and quickly small amount of the VSS should be injected. I will carefully introduce the hydrodissection cannula horizontally just beneath the Capsulorhexis edge. Lift the Capsulorhexis edge a little bit so that the cannula is just under the rhexis, and then rotate the cannula 90 degrees and quickly inject small amount of VSS. The water wave will come from the distance to this way and push the nucleus downwards so that the VSS between the nucleus and the capsule may spread uniformly in the capsular bag. Then you can rotate the nucleus quite easily. Then after, inject some visco to clear the nuclear surface for better visibility of the nucleus. inject BSS, fill up the chamber with viscose. Then with Utrata Capsulorhexis forceps through sub 2 mm incision, with this new forceps, you can make a Capsulorhexis quite easily like this. And then hydrocoat dissection with a special hydrodissection cannula. If the cortical cleaving hydrodissection has been successfully performed, you can rotate the nucleus quite easily in the capsular bag. I'll show the hydrodissection again. Push the nucleus downwards so that the BSS between the nucleus and the capsule may spread in the capsular bag and rotate freely. In phaco Prechop, there are only 2 methods you can choose according to the necessity of the nuclear support. If it is necessary to support the nucleus, vertical karate Prechop technique is used. If it is not necessary to support the nucleus, vertical karate Prechop is used. If it is necessary to support, the counter Prechop technique should be used. There are only 2 methods in the phaco Prechop. The indication of the karate technique is a soft nucleus with complete Capsulorhexis and intact ciliary zonules. In those cases, it is not necessary to support the nucleus. You can use just a combo Prechopper, and by the single action of the combo Prechopper, you can Prechop the nucleus. This is a combo Prechopper. The combo Prechopper has a combination of sharp angular blade and round blunt blade. The angular side of the blade is placed just at the center of the nucleus, and direction of insertion is just downwards. When the whole blade is buried in the nucleus, you can open the blade slowly, not quickly. If the complete division has been attained, you can observe the inner surface of the posterior capsule between 2 Prechop nuclear fragments. Place the closed Prechopper to the distal end of the nucleus, open. Place to the proximal part, open. Then, when you rotate the nucleus, restore each bisected nuclear fragment its original position, rotate 90 degrees, and repeat the same procedures. This is a combo Prechopper. It opens wider through a small incision. The rounded side is blunt, so if it is safe even at the posterior capsule. The angular side of the blade is placed at the center of the nucleus, pushing the nucleus downwards, and continue to push the nucleus downwards. Open the blade slowly. You should not open quickly. If you open quickly, you cannot separate the nucleus. Restore its original position, rotate 90 degrees, and pushing down the nucleus, repeat the opening action to attain a complete division from surface to the bottom. Rounded side of the blade is blunt, so you can safely ascertain that complete division. You will see how the nucleus is pre-chopped into smaller pieces like this. I'll show you again. The angular side of the blade is placed just the center of the nucleus, and the direction of insertion is just downwards. Pushing the nucleus downwards and open the blade slowly, from proximal to the distal end, from surface to the bottom of the nucleus. Nucleus should be completely divided. Rotate 90 degrees and repeat the same procedures. All these dividing procedures is performed under the viscoelastic material, so you can take time until you are certain that complete division has been attained. I'll show you in another case. It's quite quick and rapid. The angular side of the blade is placed and open. Rounded side is used to ascertain complete division. That's all. It's quite simple and easy. If you want to pre-chop the nucleus into smaller pieces, you can just rotate 60 degrees and pre-chop like this. Important point is continue to push the nucleus downwards and open. The rounded side of the blade can be safely used to ascertain the pre-chop. In a short moment, the soft cataract can be divided like this. But there are some contraindications for the karate technique. Those are hard nucleus. If you try to insert the blade into the nucleus, and if you have any difficulty to insert the blade into the nucleus, it is obviously not the indication of the karate technique. When the full blade can be buried into the nucleus, it is a good indication of the karate technique. For the cases with incomplete capsulorhexis, if there is a tears in the capsulorhexis, you should not force to the karate technique. But the cases with weak ciliary zonules, such as shoulder exfoliation syndrome, or the cases after vitrectomy, in those cases, karate technique should not be performed. There are only two methods in the phaco Prechop. One is karate and the other is counter Prechop. I perform all the cases by Prechop. So the contraindication of the karate technique is the indication of counter Prechop. In those cases with hard nucleus, incomplete capsulorhexis, weak zonules, I will use counter Prechop technique, provide a counter force to the Prechopper. In this technique, I'll use the sharper universal Prechopper together with a nucleus sustainer. Nucleus sustainer looks like a Sinski hook, but there is a microball attached at the tip. So we can support the nucleus at the deep equatorial portion safely. And the universal Prechopper has a sharper blade, so it is suitable to insert into the dense cataract. After making the complete capsulorhexis, the nucleus sustainer is placed to the deep equatorial portion. And the important point for the counter Prechop technique is to provide a proper counter force to the tip of the Prechopper. So the tip of the sustainer, tip of the Prechopper, and the central hardest part of the nucleus should be aligned on the same line or same axis. If you support too superficially, you cannot provide the proper counter force to the Prechopper, and you can never Prechop the nucleus. So important point is to support the nucleus at the deep point of the nucleus and the tip of the sustainer and the tip of the Prechopper, and the hardest point of the core of the nucleus should be aligned on the same line and the same axis. Bring two instruments closer and separate, and open the blade to attain the complete division from surface to the bottom. To rotate the nucleus, use two instruments and perform the same. Usually I Prechop the nucleus into 4 pieces in the soft cataract, but in case with the denser cataract, you can Prechop further into smaller pieces, into 6 or into 8, as much as you like. Support the nucleus at the deep equatorial portion, bring two instruments closer, and providing a counter force to the universal Prechopper without stressing ciliary zonules or capsular back. You can Prechop the nucleus safely like this. The important point is always the tip of the sustainer and the tip of the Prechopper and the hardest part of the nucleus should be aligned on the same line or same axis. Once the nucleus is Prechopped, I always use my phaco tip bevel down and make a complete occlusion of the tip. Using a burst mode, each Prechopped nuclear fragment can be quickly and safely removed like this, using a high flow and high vacuum setting of the phaco machine. This is a real-time surgery. Even the dense cataract can be removed like this. This is another case. Introduce a sustainer at the deep equatorial portion, tip of the sustainer, the tip of the Prechopper, and the hardest core of the nucleus should be aligned on the same line or same axis. Easily, the dense cataract can be Prechopped. Important point is to support the nucleus at the deep equatorial portion. If you support too superficially, you cannot provide proper counter force to the Prechopper. So for the myopic patient, I prefer to use a long sustainer, which has a longer tip to support the nucleus. You can attain the complete division quite easily like this. This is a case, shoulder exfoliation with a small pupil. I used 4 iris retractors to open the pupil and another 4 retractors to sustain the Capsulorhexis edge. Even in such a weakened zonules, almost subluxated nucleus, if you provide a proper counterforce to the nucleus, to the Prechop, even such a dense cataract, subluxated, can be Prechop safely using this counter Prechop technique. If you try to perform divide and conquer technique or chopping technique, the misdirection syndrome will happen, and the anterior chamber will become shallower, and the zonule will rupture more, and disaster. But all this pre-chopping procedure is performed under the viscoelastic material quite safely, like this. So to summarize, for the pre-chop, there are only 2 methods. One is karate, using a combo pre-chopper for the soft cataract, and the other one is counter pre-chop, using a universal pre-chopper and the nucleus sustainer for the dense cataract. The combo pre-chopper has a combination of round and sharp blade, and the universal pre-chopper, which is used for the dense cataract, has a sharper blade. Together with the nucleus sustainer, if you have 2 pre-choppers and 1 sustainer, you can manage any types of the cataract. If you use a femtosecond laser machine, it will cost $500,000. How much, Sagar?
$500,000, yeah, right.
$500,000?
Yeah.
But for the pre-choppers, it should be less than $1,000. With a very cheap investment, you can manage your cataract surgery quite safely and comfortably. The important point in the phaco pre-chop is to attain the complete division from surface to the bottom, from proximal to the distal end of the nucleus. Especially the posterior plate of the nucleus should be completely separated. By injecting the viscoelastic material, soft cataract can attain the complete division. But in case with rubbery sclerotic nucleus, sometimes the posterior plate is very difficult to separate. But try to insert the pre-chopper into the lower half of the nucleus, then you can attain the complete separation of the posterior plate. You have the big microphone? Now, can you hear me? Now I'd like to talk about the phacoemulsification of the pre-chop nucleus. For the phaco pre-chop, after phaco pre-chop, I use bent Harmonyx phaco chip bevel down, and I will use the burst mode. I'd like to explain about the Harmonyx chip. It was formerly called the off-centered wobble tip, square wobble tip. This tip was originally developed for the torsional handpiece from Alcon. Because the torsional handpiece, the lateral part of the tip plays important role to emulsify the nucleus. So I modified this tip from round to square so that the cutting efficiency can be maximized. And also I placed the aspiration port of the shaft to off-center to the shaft. So with this off-centeration, the tip can create a wobbling motion. Nothing happens in the round tip if you use on the torsion handpiece, but if the tip is squared, it can make a cutting efficiency, and if the tip is off-centered, it can create a wobbling motion of the tip. So by off-centering the tip, the cutting efficiency of the square tip is enhanced. And also, if the tip is bent, the wobbling movement is enhanced more. So this is the idea of the Harmonyx tip. This is a square off-centered tip, Harmonyx. As you see, the tip shaft is off-centered to the aspiration port, and the edge is rounded and sandblasted. Compared with the conventional round flare tip, the edge of the tip is smooth, and also surface is sandblasted. Please look at this video. I aspirate the posterior capsule by accident, and the vacuum is more than 500. but the posterior capsule didn't rupture. Now 390, but the capsule doesn't rupture. Why? This is the electron microscopic observation of the conventional flare tip. As you see, the tip surface is rough and sharp. There's no reason you may touch this tip to the posterior capsule. The capsule can be easily ruptured. But with the Harmonyx tip, the tip is sound blasted though, the tip edge is rounded. So it is safe. As long as you don't emit any ultrasound NH, you will not rupture the capsule. In the phaco tip, there are three types. One is straight, one is Kellman bent. The Kellman tip is most popular. Nearly 20 years ago, I invented reverse Kellman tip. My tip is bent toward its bevel. Because I always use my tip bevel down, this tip is suitable for the pre-chopping nucleus. But nowadays, for the femtosecond lasers, those who perform divide and conquer technique or the chopping technique, you may use a straight tip or the Kellman bent tip. But once you pre-chop the nucleus, I do recommend to use reverse Kellman Akahoshi tip. The reason is if you use a Kellman tip, it is very difficult to make a complete occlusion of the phaco tip to the nucleus. And also, angle of the shaft is very steep. So there is so much stress on the incision. You may have the mechanical damage or the thermal damage on the incision. But if you use Akahoshi tip, the tip is bent toward its bevel, so easy to make a complete occlusion, and all the ultrasound energy can be effectively used to emulsify the nucleus. And also, the shaft is parallel to the incision, so there is no mechanical or thermal damage to the incision. So it is very good for the coaxial small surgery. Now, I'll show you a case. You'll see this is a nuclear cataract. So it is a case for the counter pre-chop technique. Once the nucleus is pre-chopped by the counter pre-chop technique, I will use my Harmonyx tip. The tip is bent towards its bevel, making a complete occlusion with the nucleus. The small amount of the ultrasound energy is used. In this case, as you see, the CDE, the NH was 2.29. With very small amount of the NH, we can remove the cataract. Compared with a conventional round flare tip, if you use a Harmonyx tip, CDE, aspiration time, BSS consumption, in all, we can remarkably reduce the parameters. This Harmonyx tip was initially developed for the torsional handpiece, but surprisingly, I found with a longitudinal phaco machine, such as Stellaris, it can work. This is a high-speed camera image of the Harmonyx tip with a longitudinal phaco. As you see, the tip is wobbling, not on the longitudinal movement. The tip is wobbling like this. So, without using any torsional power, longitudinal phaco can be effectively used with this. With the new Harmonyx tip. So after pre-chopping the nucleus, you can use any phaco machine or any phaco tip. But if you want to enhance the phaco emulsification efficiency, I do recommend this off-centered Harmonyx tip with any phaco machine. This is a case with Stellaris using just a longitudinal phaco. Its pre-chopped nuclear fragment is almost the same efficiency as the Centurion. The nucleus was emulsified like this. In this video, only the longitudinal movement is used. The anterior chamber is very good, stability is very good through 1.8 millimeter incision. Compared with their Boschrom mixed tip, if you use an Harmonyx, APT and EPT can be remarkably reduced like this. Nowadays, the balance tip is very popular from Alcon. This is the balance tip, and that is Harmonyx tip. You will see the difference of the efficiency in the slow motion video. To test the efficiency of the Harmonyx tip and balance tip, I tested like this. The nucleus was pre-chopped into 4 pieces. First 2 quadrants of the nucleus is removed using my Harmonyx tip. Harmonyx tip has a big head, so the irrigation fluid comes laterally. So there's no forward flow to push the nucleus away from the tip. So the flowability of the nuclear fragment is quite good. I can catch the small nuclear fragment quite easily, and all the ultrasound energy can be effectively used to remove the cataract. First 2 quadrants were removed using a Harmonyx tip, and in this case, the CDE was 1.50, aspiration time 28 seconds, and VSS consumption was 11. This is an Alcon balance tip. This is a Kelman style tip. So if you try to make a complete occlusion of the tip, the irrigation, as you see here, the irrigation fluid is coming to the cornea endothelium. If you try to do the bevel side technique, there is irrigation on the cornea endothelium to damage it. And also, the complete occlusion is very difficult with this Kelman tip, so much stress on the incision. And at the end of the phacoemulsification, this is a nano sleeve, and the balance tip is so small that a forward flow to push the nucleus away from the tip. So flowability of the nuclear fragment is not good. So small nuclear fragment is dancing in the anterior chamber, and it will damage the corneal endothelium. So Harmonyx tip has a big head, so lateral flow is the main flow in the anterior chamber, but with this balance tip, the irrigation is forward and lateral and mainly to the corneal endothelium, and the forward flow will push the nuclear fragment away from the tip. So it will take longer aspiration time and also the NH to remove the half of this same nuclear fragment. With the balance tip, it required 4.24 aspiration time, 53 seconds. VSS consumption was 21. With Harmonyx, the CDE was 1.5 compared with 4.24 in balance tip, and aspiration time and VSS consumption is almost half. So you will see how the Harmonyx tip is efficient after pre-chopping the nucleus. Also for the dense cataract, almost the same result. With the Harmonyx tip, CDE was 2.27, balance tip 4.8. Aspiration time, VSS consumption is almost double. So it is very important to choose a proper phaco tip after pre-chopping the nucleus. Now for the setting of the phaco machine. After pre-chopping the nucleus, you can use any phaco machine, any phaco tip, any setting of the machine. But to enhance the efficiency of the phacoemulsification, I suggest to use the burst mode with the Harmonyx tip, Akahoshi bent, bevel down, and I will make the complete occlusion of the tip toward the nucleus, and I will mainly use a vacuum and aspiration to remove the cataract, and only when the tip is occluded, I will emit small amount of the ultrasound energy, just for the purpose of clearing the tip. If you use a pulse mode, there are so much loss of the ultrasound. In the pulse mode, the power is controlled by the foot pedal. On the contrary, in the burst mode, by the foot pedal, interval of the phaco emission is controlled. The interval is controlled by the foot pedal. For the soft cataract, I'll use a short burst, but for the denser cataract, I'll use a longer burst on time. I'll always combine both longitudinal and torsional. For the medium cataract, I use a 30 millisecond, 3 millisecond torsional time, but for the denser cataract, I'll use a 40 millisecond longitudinal and 100 millisecond torsional. According to the nuclear density, I will change the setting. For the soft cataract, the on time is only 250 milliseconds. The interval is controlled by the foot pedal. With the bevel down, pre-chopped nuclear fragment can be safely and easily removed, like this. This is a fairly dense cataract. After pre-chopping the nucleus, using a counter pre-chop technique, I use bevel down, and in this case, the on time for longitudinal and also torsional is increased. I mainly use a vacuum to aspirate the nucleus, and when the tip is occluded and the higher sound is on, I use the ultrasound NH, just for the purpose of clearing the tip. If you remove the cataract, should we approach from the periphery of the nucleus or from the core of the nucleus? I tested. This is the result. If you emulsify the nucleus from the periphery of the nucleus, the CDE was much less than if you approach from the center of the nucleus. How can we attain that? After pre-chopping the nucleus, using a nucleus sustainer, you can approach like this from the periphery. This is a fairly dense cataract. Should be a maximum density for the karate technique. You may support the nucleus, use a nuclear sustainer, and perform the counter pre-chop technique. But I could manage pre-chopping this nucleus using karate technique. And then you'll see how the nucleus is divided after injecting the OVD. Then I will approach from the periphery of the nucleus, using a nucleus sustainer. I will eat the nuclear fragment, not from the center, from the periphery. In this manner, we can reduce the total ultrasound NH. But actually, it is so quick. So just insert a phaco chip, just push the foot pedal, everything is coming in. So if you take time, you can reduce the use time. The CDE was 1.22 in this case. This is a very dense cataract. That's not so soft part. In such a case, we can approach from any part of the nucleus. After performing the complete hydrodissection, I will use a counter pre-chop technique. The nucleus sustainer is inserted at the deep equatorial portion. Tip of the sustainer and the tip of the pre-chopper should be aligned on the same line or same place. Repeat opening action to attain complete division. Carefully introduce the sustainer to the deep equatorial portion and open the blade repeatedly to attain the complete division of the nucleus. In case with the dense cataract, it is more advantageous to pre-chop the nucleus further into smaller pieces, into 6 or into 8, as much as you like. And during the procedure, if the anterior chamber became shallow, you can add more viscose to keep the chamber deeper and protect the corneal endothelium and clear the nuclear surface. Little by little, you can take time until you are certain complete division has been attained. You see, it is very sclerotic nucleus. But manually, you can pre-chop such a dense cataract. This is a Harmonyx tip. Its tip edge is rounded and sandblasted. As you see, the irrigation comes laterally, not forward way. So the porability of the nucleus is much, much improved. I will make a tip occlusion to the nucleus. I mainly use a vacuum, and when the vacuum pressure increased, I always hear the sound of the phaco machine, and the vacuum increased, I will emit the short burst just for the purpose of clearing the tip. There is no loss of the ultrasound NH. All the NH is used to emulsify the nucleus. controlling the nuclear fragment. Each Prechop nucleus is modified quite easily and rapidly like this. The irrigation flow is always lateral, and always the flow comes to the phaco tip. The probability of the nucleus is excellent. Even such a luminescent dense cataract, you see, the CDE was 9.86, less than 10 with the CDE. We can remove such a dense cataract. There's no mechanical or thermal damage with the incision. Just increasing the intraocular pressure, the incision can be sealed. So the microcoaxial surgery can be successfully performed using this Harmonyx phaco tip. Now for removing the cortex, it is also important to use a small IA tip. The conventional standard IA tip has an outer diameter of 1 millimeter. The silicone or polymer tip has 0.85, and my mini IA tip has only 0.7 millimeter. So the amount of the irrigation into the anterior chamber through a nano sleeve is almost 3 times more than the conventional IA tip. So the probability we can keep the deep anterior chamber, and we can reach any part of the capsular bag with this IA tip. This is a curved mini IA tip sandblast, and this is my favorite ball IA tip. The aspiration port is drilled 45 degrees to the main shaft, so I can easily make a complete occlusion of the posterior capsule, and I can safely vacuum or polish the posterior capsule. And the tip is ergonomically curved, and also the amount of the irrigation is enough. I can keep deep anterior chamber, and even subincisional cortex can be easily removed, and the posterior capsule can be safely aspirated or polished using this spherical configuration of the IA tip. To attain the completely clear posterior capsule, I have the IA tip sandblasted, and also my sleeve. This is a special sleeve. I'll talk about the sleeve at the ESCRS in Copenhagen. This is a special sleeve with a sandblast. Using this curved IA tips, using this part of the sleeve, you can gently polish the posterior capsule. After removing the cortex, like this, the posterior capsule can be safely cleaned using the back surface of the posterior part of the sleeve. You'll have the completely clean posterior capsule like this. This is a polishing cannula. Sometimes the dense opacity may be attached on the posterior capsule. I will attach this cannula to a syringe, and then after implanting the intraocular lens, I will use this cannula to clean the posterior capsule. Firmly attached opacities can be removed like this. So I have the hydrodissection cannula in the same purpose. So the key to the successful mix is wound protection, and to keep a stable anterior chamber, use a good fake machine and the Harmonyx tip. And another important point is astigmatism control. As you know, the astigmatism is a combination of corneal astigmatism and lens astigmatism. This is a total astigmatism. If you perform the larger incision in the cataract surgery, even though the cornea is perfect, after the cataract surgery, you induced astigmatism by the surgery. If you make the incision size smaller, you will not induce any astigmatism after the surgery. This is a mix. But if the patient had pre-existing astigmatism, we cannot treat this astigmatism by surgery, even though we use a micro-incisional technique. So in such a case, to treat the astigmatism, there are two ways. One way is to implant the conventional IOL and perform the LASIK to correct the astigmatism. But my idea is to implant the toric IOL and correct the astigmatism. The former surgery is aimed not to induce an astigmatism, but now my concept is to correct the pre-existing astigmatism by surgery. So my strategy is micro-incisional cataract surgery plus toric IOL implantation. For the astigmatism control, nowadays we have the very good toric lenses, but the important point is how to align the axis during the surgery. There are many very, very expensive equipment to adjust the axis. It costs $400,000, $500,000, but it is not possible to use in our daily practice. Because if the astigmatism control is very important, because 1 degree of misalignment will lose 3% of the toric effect. This is a conventional toric marker with an air bubbles. The surgeon couldn't concentrate on the patient eye and the air bubble at the same time. This is an electric toric marker. You will hear the sound. If the machine device is tilted, it will create a beeping sound, and if it's completely horizontal, the beeping sound will stop, and the green light is on. So the doctor can concentrate on the patient eye, and from the sound, we can see the position of the device. This is a single action electric axis marker. By a single action, we can make the marking on the patient eye. But in Japanese patient, sometimes they have the very narrow lids and difficult to use this device. So I always use this reference marker. This is very convenient for the small eye or deep set eyes. I will make 0 and 180 position using this reference marker. And during the surgery, I use this intraoperative gauge. The conventional intraoperative gauge is huge. It was placed on the corneal limbus, so the diameter was 14 millimeters. So even after opening the eye with the spectrum, sometimes Japanese eye was difficult to use this device. But this is my new intraoperative axis marker. It is placed on the cornea. The diameter is only 10 millimeters, so it is quite easy to place on the cornea. There are two arrows which will be adjusted to the reference markers and the dial to set the final axis. There are the two blades to mark the final axis. And also, I made a guideline for the size of the ideal Capsulorhexis. I'll ask the patient to sit up and look straight. I'll hear the sound of the device. When the device is completely horizontal, it stops beeping and the green light is on. I can concentrate on the patient eye. When the beeping sound is stopped and the green light is on, the device is horizontal. So quite easily, I can mark the patient. I'll show you a case. This is another case. But after marking the 0 and 180 position, this is an intraoperative toric marker. You can mark the final axis, and also you can see the guideline for the ideal Capsulorhexis size. This is a fairly dense cataract with great nuclear 3- or 2+. So I need to perform the counter Prechop technique. I always approach from the temporal side of the patient. I measure the incision size. In this case, 2 milligauge doesn't go in. So it is 1.9 intracameral anesthesia, lidocaine 0.5%, preservative-free, and viscose is injected to fill up the anterior chamber. And this is my Utrata Capsulorhexis forceps. Through this sub 2 millimeter incision, the manipulation of the capsule is quite easy. Along the marked Capsulorhexis mark, I will make a Capsulorhexis without tears or notches. And the hydrodissection is performed with a bent 27 gauge special hydrodissection cannula, clear the nuclear surface. And this is a myopic patient. I use a long sustainer to support the deep equatorial portion, and with a universal Prechop counter Prechop is performed. The nucleus is now Prechopped into 4 pieces. For the phaco emulsification, this is a Harmonyx tip, Akahoshi bend. The tip is bent toward its bevel, and the irrigation is coming laterally, so the probability of the nucleus is good. In myopic patient, because the patient complains some pain, the maximum pressure is 80 millimeter mercury, aspiration flow rate is 40, and I will use my phaco tip bevel down and make a complete occlusion toward the nucleus. And when the tip is occluded and vacuum increases, I will use a short burst for the clearing the tip. There's no damage, thermal damage on the incision. And this is a curved IA ball tip. The tip is curved, so subincisional cortex can be safely removed using this ball IA tip. The amount of the irrigation is enough into the anterior chamber. I can keep a deep anterior chamber. To implant the lens, I always use a cohesive Probisc. This is a myopic patient who has a past history of ocular trauma. I implanted the capsular tension ring using universal forceps. And this is Acrysoft toric, providing a counterforce through 1.9 millimeter incision, 6 millimeter optic toric lens can be safely injected using a Royal injector. To remove the viscoelastic material in the anterior chamber, I use a nucleus sustainer to control the lens position. And the posterior capsule opacity is carefully polished. This is another type of the polisher to clean the posterior capsule. And the radial cortex is aspirated, again, using IA. This is the final axis, and you will see the marking of the lens. Using a hydrodissection cannula, I'll finalize the lens position, and the Capsulorhexis edge is on the optic, thanks to the electric toric marker, guiding mark. So I'd like to explain step by step what instrument is necessary for this surgery. Before I starting the surgery, I always preset the lens. My nurse will do this. This is a special rolling forceps for the Acrysoft, and this is a Royal injector, unihand injector. In our operating theaters, we have the magnifier with LED light. So before starting the surgery, our scrub nurses will prepare the lens. This is preloaded, like this. So even the dark place, this LED will illuminate the field. The important point is 1 drop more Probisc at the port of the D cartridge, and this is a special rolling forceps for the Acrysoft. It has a rectangular blade like this. By deep grasp, the lens is picked up like this. The leading haptic is bent over the optic, and trailing haptic is shallowly held, just insert. That's all. With this special forceps, the rolling of the lens is quite easy, and even our scrub nurses can prepare the lens perfectly. So before starting the surgery, the lens is ready on the table. To open the patient eye, I always approach from the temporal side of the patient. This is a speculum. For the deep set eye or the narrow lid cases, I prefer to use a 3-prong speculum with a small size. And I had designed a special drape for a quick draping. This drape is pre-cut. So just like this, in a moment, the draping can be finished. As you see here, the drape is pre-cut. So upper and lower lid is simultaneously covered like this. So it is not necessary to cut the drape. Important point is that the meibomian secretion should be completely blocked by draping. Otherwise, even though you have the meticulous cleaning of the lid, there might have the higher risk of the infection during the surgery. But in this drape, as you see, upper and lower lid is completely covered. So there's no contamination of the surgical field during the surgery. So marking the axis, I use electric toric marker before sterilization. And during the surgery, I use this intraoperative markers. I set the final axis under the microscope. And the paint, I prefer to paint only the blade. There's a reference markers. The arrow is set to the axis and press down for a while, and you will see clearly the guide for the capsulorhexis is made on the cornea. For the incision, I prefer to use a diamond blade. There are two types of the diamond blade. If you want to perform the sub 2 millimeter incision, this I'll use nano diamond keratome. For the 2 to 2.3, I'll use ultra diamond blade. At the shoulder, it is 2, and at the base, 2.3. So according to the lens power, if the patient is hyperopic and the lens is thick, I may make a little bit larger incision. If the patient is myopic, I may, if the lens is thinner, I may use a small incision. For the side port incision, I prefer to use a small blade because during the countertraction implantation of the lens, if the intraocular pressure is not high enough, you will fail to implant the lens. So normal side port knife should be 1, but I prefer to use 0.6 small blade for side port incision. In this case, I use nano diamond blade. At the shoulder, 1.7, at the bottom, 2. In case with shallow anterior chamber or the floppy iris syndrome, I may use a 2-step incision, but otherwise, I just make a single plane incision. This is a small diamond blade for side port. During implantation of the lens, to prevent the leakage of the OVD, I make a small incision, side port incision. The main incision size is 1.9. And then for the Capsulorhexis, this is the same design of the Utrata Capsulorhexis forceps. But the blade itself is very thin, so you can easily manipulate through sub 2 millimeter incision. After intracameral anesthesia with 0.5% lidocaine preservative free, the chamber is filled with dispersive viscoat. There's a tip to puncture the capsule. And immediately after puncture the capsule, I can grasp the capsulorhexis edge and make a rhexis a little bit smaller than the optic size, like this. This is a hydrodissection cannula I designed. It is a 27 gauge cannula, bent, and the tip is tapered. So at the end of the surgery, sealing of the incision is quite easy. With this cannula, the hydrodissection is quite easy. The nucleus can rotate freely quite easily. The important point is to use a small syringe, not a big one. For the pre-chopping the nucleus, for the soft cataract, I always use a combo pre-chopper, but in case with the dense cataract, cases with weak ciliary zonules, or in cases with incomplete capsulorhexis, I prefer to use this universal pre-chopper together with nucleus sustainer. In a myopic patient, I I will use a long tip sustainer so that I can support the nucleus at the deep equatorial portion. This is a long sustainer compared with a normal sustainer. It has a longer tip so that I can reach the deep equatorial part to support the proper counterforce to the nucleus. For the phaco emulsification, I will use a Harmonyx tip on the Centurion. With this machine, the anterior chamber is so stable. Before I use the Centurion, I needed to hire the bottle very close to the ceiling, and I needed to bend over the patient with a lower table. But with this good fluidics, with the Centurion, we can perform the surgery quite comfortably. This is a new nano sleeve. There is an inner ridge in the sleeve to prevent the thermal damage of the incision. The irrigation fluid always comes laterally with Harmonyx. Prechop nuclear fragment is emulsified using a burst mode with combination of longitudinal and torsional. Through this sub 2 mm incision, Prechop nuclear fragment can be removed quite quickly like this. To remove the cortex, I'll use ball IA tip. There are 3 types of the ball IA tip: straight, bent, and curved. My preference is curved ball IA tip. It can reach sub-incisional cortex quite easily. The amount of the irrigation into the chamber is almost 3 times more than the conventional IA tip, so the capsular bag is huge, and I can reach many parts quite easily, and I can safely polish the posterior capsule using this tip. For implanting the capsular tension ring, I just use universal forceps. I don't need any injector for the CTR. Fill up the chamber with Probisc, and controlling with a nucleus sustainer, which I use for the counter Prechop technique, I can implant the CTR quite easily in the capsular bag like this. For lens implantation, even the D cartridge, the cartridge can never insert into the anterior chamber. Important point is to provide a counterforce so that this part is firmly attached to the incision, and then elbow of the acrysoph will come into the incision, and it will stretch the incision little by little, and through this sub 2 mm incision, 6 mm optic lens can be safely injected. The important point is during implantation, we should keep high intraocular pressure. If the pressure is low, you will fail to implant the lens. So to minimize the amount of the leakage of the OVD through this side port incision, I use a small side port blade. To implant the lens, I always use a cohesive type of the viscoelastic material because it is easier to remove after implanting the lens. For the posterior capsule polishing, I have several types of the polishers, but this is a ring polisher. The inferior side of the polisher is sandblasted, and the irrigation comes here. So I can gently polish the firm, dense opacity on the posterior capsule can be safely removed using this ring polisher, which is attached to the 2.5 mm syringe. And the residual cortex and debris are removed. And then just increasing the intraocular pressure, the incision can be sealed. And thus, I can make a high quality of the cataract surgery for each patient. Now, finally, I'd like to talk about the quantity of the surgery. How can I manage many cases? I operate 60 cases a day, more than 10,000 a year. How can I manage this high quality of the surgery? Occasionally, we have such complicated cases, but in Japan, in Tokyo, more than 80% of my cases is grade 2 cataract, quite easy to operate. The easiest way to operate is to operate quickly. This is very old video. I used a legacy fake machine. I used a soft shell technique using Provisc and Viscoat. This patient had a problem on the respiration. She couldn't lay down long time on the operating table. So I needed to operate quickly. The basic technique at that time was the same. There's no change. I approached from the temporal side of the patient using a diamond blade for the incision. I used a combo Prechopper to pre-chop the nucleus. And this is not a square tip or the flare tip, but I manually bent the tip toward its bevel to make Akahoshi bending. With the cortical cleaving hydrodissection is successfully performed, there is almost no cortex remained when I removed the nucleus. So I used an old Monarch injector screw type to inject the clear acrysop, and then the radial cortex was removed together with viscoelastic material. This is real time, 1 minute, 90 seconds, 20 seconds. So at the end, I just increase the pressure, the incision can be sealed. So in 1 minute and 20 seconds, I could finish the surgery. But the speed is not the way I want to go. The efficiency is important, because if you take a longer surgical time, there is more risk of the endophthalmitis due to the contamination of the surgical field. If the incision is smaller and the surgical time is shorter, there's less instance of the endophthalmitis. So to reduce to perform the operation efficiently, there is one way to reduce the operation time by the surgical techniques such as the Prechop, or use a new technology such as the Harmonyx or the Centurion machine. But much more important point is to reduce the non-operating time. For that purpose, important point is the preparation and quick patient exchange. So I have already talked about how to make the surgery efficient, but to reduce the non-operating time, perfect preparation and quick patient exchange and the teamwork of the staff is important. This is a surgical schedule of 1 day for me. I operate 60 cases. In the morning session, I operate 30 cases. In the afternoon, I have 2 sessions, 15 each. These orange patients operate bilaterally, and these red, the cases of the toric. You will see how many, I have so many toric patients like this. And there is a detailed information is written on this schedule. At a glance, I'll see what type of the patient. So according to this data, I'll change the setting of the fake machine and I choose the instrument. This is a table for my surgical instrument. I don't prepare so many instruments, only the blade, pre-choppers, and the lens already set. I have such the basic set, 40 set sterile in advance. And everything is prepared in advance. Gloves and drapes, like this. I have the 40 sets. The normal custom pack should have 1 set of the drapes and the cups and syringes inside. But my custom pack had 7 sets inside. Once the nurse opens 1 set, there are 7 instruments is ready. So preparation is important, and also the lens is set by nurse in advance. In the waiting room, the patient is prepared like this. The patient has the pressure cuff like this, and the ERG cable is attached, and she has a line already. So when she moves to the operating theater, just connect. So to minimize the preparation time in the OR. And this is a drape. Formerly, we took a long time for draping the patient, but with this slit drape, we can prepare the patient quite easily. In the hospital, I have 2 rooms with exactly the same settings. microscope, centurion, and the table, and each operating theater, I have an assistant nurse prepare everything like this. So I can quickly move between two rooms to perform the surgery. But in clinic, I have only one fake machine, centurion, one microscope, but I can manage exactly the same number, 60 cases a day. How can I do that? I have two tables. This is a chair, electric chair, but it will become a surgical table. So I have the microscope and two tables and one fake machine. I have 3 scrub nurses and 1 circulating nurse, and I am the only surgeon in this operating theater. The first nurse assists the surgery, and the second nurse makes a skin preparation and the intraocular lens setting, and the third nurse prepares the instrument. And the 4 circulating nurse take care of the patient. There are the movement of the nurses, how they move. It is fixed. But I think it's easier to see the video. The patient is coming here and sit, and automatically it will recline to make the surgical table. And my scrub nurse will prepare the scrub, clean the patient eye, and I come here and look at the list of the surgery, and all the information is input now, and I indicate the setting of the fake machine, and I tell them which Prechop I will use. The draping is done by nurses, and then I come and sit down and start surgery, and then finish. While I'm changing the globe, the next eye is prepared by nurses, and the next patient is coming to the next chair, and while I'm doing the surgery, our scrub nurse will prepare the patient. I'm almost finished the surgery. I see the incision and finish the surgery now. I don't patch the patient because it's a topical anesthesia. Immediately after the surgery, patient can see and come back on foot, and this patient is already prepared and moved to their surgical table and draped, and I can start surgery like this. Between changing the patient, it takes only 30 seconds. In 30 seconds, I can operate the next case. Thus, I can operate 60 cases a day. Then, how can I operate 10,000 cases a year? This is the surgical schedule in 2016. I will operate 355 days. I have only 10 days holiday a year. So I need something like this in Bali. Thank you for your attention.